Okay, friends, good evening. Welcome you all to this session. I'm Dr. Anil Ganju from India, waiting for my co-chair, Dr. Brian. So this session is about body contouring and why it fails, maybe the complications that we are going to hear from our speakers. The first speaker is Dr. Uh, Ufir Atzi. Okay, he tells us about the subdermal fractional radiofrequency remodeling for skin. Dr. Ufir, please.
So hello everyone, it is great being here. I think I'm going to present this study, it's me, for the first time. This is a three-center study, and although I work closely with all companies, nothing to disclose here. So I want you to look at these patients. This is the first one. Oops, I don't know what happened with the, there is a problem with the AV. It happened with another presentation in the previous room. But whenever you have a very saggy, heavy face, it happened in another room. You have a problem with the AV, with another presentation, okay? Different. How can you solve it? So I think most of you, especially if you're aesthetic physicians or dermatologists, you offer very mild procedures. However, unfortunately, the result will be very subtle. And I'm not sure it's going to satisfy you or your patient. So if you really want to you have heavy face, distorted jawline, submental fat, and you don't want to go through a surgery, you have to go aggressive. So either to perform liposuction or to use any of the procedures, what we call X-assisted liposuction. So it can be laser, it can be helium driven, it can be radiofrequency. And I have to say that I had quite a journey. I have been in the market for the last 17 years. I had quite a journey with these patients. So I love to do liposuction. Whenever you have fat, you have to take the fat out. I have to say my hands, and this is my opinion, with lasers, I have relatively subtle results. So the tightening is not enough. The fat, there is no problem to really dissolve it and to take it out, but this is not the main idea. I was the first one who published this paper on the face tight. Again, no financial interest. However, I have to say that although I was the publisher, so I wrote it, I never knew where to stop. So I felt as if I overcook the area, and I had problems. Not that I had complications. I didn't have many. But in the end, to be in the place in which you cook, and you say like, okay, where do I stop? And then I moved to J Plasma. I had actually very, very good result. However, I had one case in which the helium gas precipitated into just below the eyes. So this patient developed retrobulbar kind of air gas accumulation. Everything was okay in the end. She was hospitalized for 2 days. I freaked out. The patient freaked out. But then when they had this warning of the FDA for gas accumulation, I said, not for me. I want to sleep at night. So this is the reason that when this device came into the market, this is a new device. It was launched 2 years ago. It's by InMode, again, no financial interest. But the idea is that you have very short burst of energy in between two. You see two you have two electrodes, and the propagation of heat is very, very superficial. And what you see, and this is very important, that in the end, with every pulse, you have 0.03 milliliter destruction of fat. So in my hand, it's very reproducible, and they develop some tables that you can really count how many pulses you provide and how many or how much fat you dissolve. And I felt really safe to do, and this is the reason I started playing with. I was probably one of the first ones to play with the device, and this publication will come out very soon. This is the first time that I really present the publication. So this is 3 centers. This is Fadi from Ramallah, plastic surgeon Evgeny is from Bulgaria, and my center, 3 years, we had 33 patients in which we wanted to see a long follow-up. So 9 months, until 9 months of follow-up in order to see. So this is going to be published. It's a retrospective multi-center study. I told you 3 centers, 33 patients, 9 months of follow-up. And in the end, this is, by the way, not different from what I used with J-Plasma or with FaceTite. So you had 1, 3, or 5 entry points. One, this is a must-have. These 2, you can have them, and this one, most of the people do not use them. So you see, this is an office procedure. So I just first put tumescent, that's what I do. Then what I do, I kind of like you dissect the skin of the fish, so you create a space. Then I just put the quantum, so the probe. I have a specific amount of pulses, so I'm very accurate. And then it's not a must, but I actually remove some debris. It's not really fat, but I want to really maximize the result and to hasten the recovery. So the photos before and 6 to 9 months after procedure were sent to 3 non-involved dermatologists, and we actually asked the patient. And I want to share with you for the first time the result. So we used standardized validated scale. So these are the scale. You can see this is the scale for the fat. This is the scale for the laxity. We sent the scale to the patient, and we asked the patient to evaluate the before and after, 6 to 9 months after procedure. I even didn't know how this area, I would say, bothers the patient. There is a psychological scale. It is called a submental fat psychological scale. And it really, like, patients do not take picture from this angle, so they wear certain clothes. So there is a really a burden for this area. So we checked the change of this scale, and of course, satisfaction and any adverse reaction. So I won't get into details in the sake of time because I want to show you many cases. However, 33 patients, you see we had more female patients. This is the average age. This is the BMI. I want to show you that in the end, we injected in 3 centers, again, 33 patients. So this is the average, so 100 cc of tumescent in order to perform the procedure. We aspirated 16.3. It's very little amount. You don't really, as compared to other areas, you don't really aspirate fat. It's mostly debris. And you can see that the VAS is below 3. Whenever it's below 3, this is like toxin. This is like filler. So it's not very painful, especially with the tumescent. And the recovery time is very, very short. However, it's a lie. Why? Because my patients, and in Bulgaria, it was 6 to 7 days. In Ramallah, it was 2 days, 2.5. So I called the person and I told Fadi, come on, how come you have such a short recovery? She said, there is no problem. They just put the burqa, they put the hijab, and they go back to work. So this is really not, so, maybe we can mention it in the discussion. We mention it because you can see it's not painful. You can go back to work. But in Israel, for example, no one will go to work with looking like Teletubbies, okay? So, but this is probably the difference between other areas. You can see I want to skip this one. I want to emphasize the results. So whenever you look at this scale, very dramatic. So this is the objective, 3 non-involved dermatologists, so 60.9% improvement. And actually it is validated because the patients actually had nearly the same score.
We'll have to hurry up, please.
Yeah, I'm finishing. And whenever you talk about the laxity, even the laxity was improved as well as the psychological impact. Nearly no serious adverse reaction all the reaction was transient. So these are my patients. You can see dramatic result. Again, very, very dramatic results for any patient. This is from Mala. Have a look at the change of the contour. Again, another patient in which you see result, and this is from Bulgaria. So dramatic result. And we combine. From this paper, you know, now it's going to be accepted for publication, but these are patients from a year or 2 years ago. We learned a lot. So we combine it with, for example, Morpheus. We call it inside-out tightening, and we have very good result. I'll skip this one in the sake of time, so how to exactly do it, but you can see that we have very dramatic result. The results take time. So you see the change with time. This is baseline in 9 months. We combine it with threads. So in the procedure, so after doing the result, I put threads, I reposition, and then I put the support. Very dramatic result. It's amazing. Okay, I'll check it with the AV after, but you see the dramatic result that we see with this combination. And we combine it with fillers. For example, this young lady, you can see her result just in the end. We put, this is the jawline that was restored, so we put drops of fillers and in the chin, so you can see the very dramatic change. This is the result, dramatic changes. So the take-home message, I think nowadays, if in the past you had to really go aggressive if you wanted to have a very good result, nowadays you can use, I would say, less aggressive procedures and still to have very good result. I showed you just Quantum RF was very safe, very, very good result. And if you combine it with other modalities, then you take it to the next level. Thank you so much.
Thank you, Urfi. Just wanted to know the depth of the needle, the MNRF that you did over and above.
Usually what we do, so again, it was a learning curve. And in the end, what we do it, it's in the fat. So we do it in 2 levels, one in the deep fat, okay? So we push the edge of the probe down, and one I push the edge of the probe up. So just like, so it's like the superficial fat and the deep fat, okay? But again, I'm talking about the hypodermis. So you want to first dissolve the fat, and second, to contract the fibroseptal network.
So that would mean at least 7 mm depth?
Yeah, yeah.
Okay.
The deep one for sure. The superficial, I believe it's going to be less, 3 to 4.
Okay, thank you.
Thank you so much.
We'll move on. We'll have more questions if you have towards
I have
the
to
end.
leave to another symposium.
Anybody wants to ask anything, Urfi? Yeah, please come up. Yeah, yeah.
You mentioned, Doctor, the Ignite RF. That's the machine you're using.
Again, in?
The Ignite RF.
Yeah,
That's the name of
yeah. This is I didn't mention because it's not sponsored, but yeah.
And it's 29 degrees to 32 degrees, the heat.
It gets to higher the degrees because it has to dissolve fat. It is called Quantum RF 10. You have several types for the body. Fortunately, I don't do body. So whenever I talk about body, this is the only non-facial area that I treat. I have a plastic surgeon working in my clinic. He does all the other areas.
So you don't get burns.
Look, I didn't have, so far, I exceeded 200 cases. So this was like the first one with really like 9 months follow-up. I didn't have one case of burn, one case of marginal mandibular paresthesia, which I had with different devices. I think because it has an internal temperature monitoring. So whenever you get to the point in which it's too high, it just stops. And then it's like, it doesn't let you go. It's very safe, very safe.
Okay, we'll have to move on. Sorry, questions at the end now. Thank you very much.
You catch me, I'm here, okay?
Okay, so we move on. We have Dr. Pellin, who talks about gluteal aesthetics. This is tissue regeneration with the PLA for the gluteal region. Yeah. Dr. Pellin, please.
Hello, everyone. I'm Associate Professor Dr. Pelin Eşme from Ankara, Turkey. It's a great honor to be on this stage. Today, I will talk about the importance and the role of polydilactic acid in the redefining gluteal aesthetics, tissue rejuvenation, and also contouring with combination of both cross-linked and non-cross-linked hyaluronic acid. Of course, throughout the human history, the gluteal region has been a focal point of art and aesthetics, serving as a fundamental symbol of physical attractiveness, beauty, fertility, particularly in human, focal points of aesthetics. But nowadays, it's a little bit important because nowadays people losing their weight easily thanks to GLP-1 analogs. We call that as a Ozempic phase, but nowadays we know that the sagging effect, reducing in collagen, elastin, losing muscle, and reduction in fat, adipose tissue could be seen in buttocks and also gluteal region. So people are losing their weight easily, but they want to beat full gluteal regions. So actually we have some approach and procedures including surgery. Surgery is one of the best because excellent results, but implant complications up to 20%, and there can be a fat embolism risk, and also expensive, time consuming. There's a time procedure to healing of our patients, so there's an increasing demand for minimally invasive procedures. But I would like to underline that features about not only volumization but also regeneration. In the past, our patients comes to us with the demand with bigger gluteal regions, but nowadays they comes to increase with the demand of increased skin quality. This is our protocol. Why PDLA? I'd like to combine PDLA because PDLA is different from PLA. It has no spiky components. So in the PLA, spiky components induces aberrant inflammation, but in PDLA, it's a more spheric component. So it induces and causes to more balanced inflammation procedure and response. So I'd like to combine both PDLA and hyaluronic acid. On the other side, PDLA collagenizes tissue remodeling and progressive improvement. And I like to combine with hyaluronic acid, with cross-link and also non-cross-link hyaluronic acid. You know that both of them decrease the wrinkle severity, increases collagen, elastin, but hyaluronic acid causes us and supports the structural components and projection immediate lift. We will see the procedure. By the way, as you see here, if we think gluteal region is a one part, we are mainly focusing on the upper part. Of course, lower part is important. If you have enough material, you can use to mainly lower and outer part of the gluteal region, but upper part is very important. So we would like to create some overlapping fanning areas to induce and stimulate the collagen and elastin. Let's look at the video. Could you help me to?
Not able to click it. Can you help, please? Click the video.
Yes. We marked two areas for PDLA injection. I use local anesthesia with adrenaline epinephrine for injection points, entry points. And then I use 18-gauge cannula and needle for the injection, you will see. This is for biostimulator effects. You can think that PDLA creates the framework or skeleton of the home, but we will create, and in the second part, with the hyaluronic acid as a contouring effect in the upper side. Like on molar area, we use some materials for makeups. We use hyaluronic acid on the upper side for light games. If you have enough, by the way, I use one vial for per site. One vial includes 450 milligram PDLA and non-cross-linked 150 milligram hyaluronic acid. In the upper side, I'd like to combine with high G prime hyaluronic acid. Actually, there is no serious adverse effects after this procedure. You can go everywhere. A little bit pain, sometimes a little bit ecchymosis and hemorrhage areas could be seen.
Dr. Pelin, what anesthesia have you used?
Yes.
What anesthetic have you used? Have you given tumescent in this?
No, only injection points, for injection points.
Only into the entry points?
Yes, only for entry points with the adrenaline. As you see here, we completed the procedure. These are 6 months follow-up. According to the doctor's evaluation, more than 60% of our patients, according to the more than 60% of our patients reported they experienced very much improved, and we didn't evaluate and observe any serious adverse effects. Let's look at some of our results. This is one of the immediately after photographs. I would like to underline again, for each gluteal region, I'd like to use one vial that includes 450 milligram PDLA and non-cross-linked 150 milligram hyaluronic acid for per site. You can easily realize that there's a little bit volumizing effect. Actually, there is no cross-link hyaluronic acid, but a little bit lifting effect immediately after. This is very aesthetic gluteal region buttocks, but this is the best one. And the second one, you can see and you can realize there is a, it's clearly observed that this line and some dimples are not seen in after photographs. It will be better at third month. This is one of two 27 years old girl, 3 months follow-up photographs. There is no cross-linked hyaluronic acid. We achieved a very good improvement on dimples and cellulitis areas. According to in this lady, very sportive woman, very fat, very fit, but cellulitis and dimples could not be solved sometimes. Pilates, sports, and other things, diet and restrictions. We need some injections. I like this lady because this is one of my favorite person, one of my favorite patients, because rapid weight loss during the Mounjaro treatment in 1 month, nearly 15 kilograms rapid weight loss. You see the results 3 months follow-up. We made this procedure before the Mounjaro treatments, and then she started the Mounjaro treatment. You can realize that one vial 450 milligram PDLA and non-cross-linked hyaluronic acid, but each site we used on the upper part 10 milligram cross-linked high G prime hyaluronic acid per site. She lost weight nearly 15 kilogram, but you can easily realize that there is no cellulitis appearance. It's more lifting, contour effects, more shaping area. And another person, she's also during Ozempic treatment, 3 months. In the 3 months, she lost 10 kilogram. We also combined with PDLA, non-cross-linked hyaluronic acid, and a high G prime hyaluronic acid. This is the 3 months follow-up results. And another one, this is a young lady. She makes also sports 3 times a week. But you see there is no pregnancy, she is not married, but you see maybe during the growing phase of adolescent period, there are a lot of strial lines. I made several times CO2 laser, but you see the 3 months follow-up after wrinkles, strias, and cellulitis appearance with the PDLA and hyaluronic acid combination. And another patient during Mounjaro treatment in 1 month, nearly 10 kilogram rapid weight loss. You see the 3 months follow-up results, and this is the 6 months follow-up results. Combination with PDL8, non-cross-linked hyaluronic acid, and 5 milligram high G prime cross-linked hyaluronic acid in both sides. You can easily realize in the center of the gluteal region the lifting effect and contouring. And this is my last slide. This is my last patient. There is no hyaluronic acid. You can easily realize that from the lateral view, there is a little bit sulcus obsession in this area, but it's very good improved in the 3 months. This is the results of at the end of the 6 months. You can easily realize there are a lot of dimples. Yes, we can see still there are, but it's very improved. As a result, as a conclusion, I'd like to underline that in the past our patients are coming us with the demand of bigger shapes, bigger gluteal regions, but nowadays the feature is not only volumization, the feature is about combination of regeneration and volumization. So I'd like to combine PDLA for rejuvenation of gluteal region because there is no spike components, and in this is the inflammation, very balanced behavior in our skin. And hyaluronic acid, I like to combine non-cross-linked and cross-linked for support. So lifting, contour, skin quality, and collagen in demand of the increase in collagen, we will be here a lot of in the next years from our patients. Thank you for your patience and for your listening.
Thank you, Dr. Pelin. Please stay back. We'll have questions towards the end of this.
Okay, thank
you. And now we have Dr. Choi, who talks about combining toxins and fillers and giving a synergy in the neck and shoulder sculpting. Dr. Choi, please.
Hello, everyone. Dr. Choi, Ho-Sung Choi from Korea. So nice to meet you. Okay, my slides are ready. So my talk is about body contouring, especially focusing on neck-shoulder silhouette using toxin and HA filler in combinations. This is me, and I declare that my lecture is non-sponsored lecture. So let's talk about background first. So the foundation of this treatment concept is to create a smooth and well-defined shoulder contour, especially in sleeveless outfits. So an elegant shoulder line refers to a clean and right-angled shoulder, not excessive volume, actually. It is characterized by a straight lateral line and a sharp shoulder break, like these ladies. And tight shoulders or short neck are often associated with dominant upper trapezius muscle, and which gives less distinct transition from the neck to the shoulder. So it is important to consider the neck-shoulder region as one aesthetic unit. My approach is a two-step logic. The first one is debulking the overactive trapezius muscle using toxin injection and enhancing what is missing, which is the shoulder projection using HA filler. And this approach can create the appearance of a longer neck and a more refined feminine upper body silhouette. Like her, you can see a typical candidate. The plan may be changed depending on the dominant factor, muscle versus structures. So usually I combine these two steps for our patients, and the result is quite good. Do you like it? Okay. Actually, in real practice, most patients benefit from micro changes, not aggressive correction. So the correction should not alter the patient's natural posture or comfortable movement. These are suitable indications for this treatment concept. Relatively younger age group they get more benefits, and those who feel self-conscious about having narrow shoulders with enlarged trapezius muscle that make the neck appear shorter. So let's talk about the products. Since body contour correction typically requires a large volume of HA filler, so my top priority is safety. So the filler should have less allergic, to be less allergic, and it should contain lower amount of BDDE. And the next, I consider the filler rheological properties, which suit high cohesiveness, high G prime, with less migration. Let's talk about injection technique now. Fortunately, when injecting into the shoulder, apex of the shoulder, there's less significant structures as long as you respect the superficial fat layer. And because most of veins or nerves are located quite deep plane, so if you don't go deep, almost no likelihood of injury of these structures. And in general, I make the first entry point just on the acromion. But if the acromion is too prominent, you better move a little posteriorly for ease of injections. And not only one entry point, I frequently make 2 to 3 entry points to cover large area and to create even distribution of filler. Just like that. And during injection, it is essential to carefully control the filler volume so that the center of the injection area receives the greatest volume of filler. And you need to avoid any boundary lines. And right after injection of 20 mil, so 10 mil per side, is quite enough, sufficient to create good contour, better contour. And on top of that, a well-defined collarbone enhances this upper body silhouette elegance and more feminine. And usually when you augment collarbone, then you can give an overall impression of grace and sophistications. Usually I use 2 mil per side using high G prime HA filler, and cannula is more preferred than sharp needle, and I use 19G cannula. And I usually puncture 2 entry points from the side, and I create a continuous line. And the injection plane is right on the bone, deep enough. And when these 2 treatments are done in combination, you can create a more refined and well-defined upper body contour. And lastly, for the toxin, I reconstituted 4 mil of Nomosaline into 100 unit so that I can get 5 units per 0.2 mil. It's easy to calculate. And for shoulder, trapezius muscle, I usually inject 25 to 30 units per side, up to 70. And the injection points should not be too lateralized or medialized. So these are optimal entry points. And I make 5 to 10 points per side using 30G half-inch needle, and I go vertically. But during injection, you need to pinch the muscle, not to go too deep. And if the patient is suffering from tension headache from the posterior neck, then you can also inject intradermally a small amount of additional toxin. So it's not only for cosmetic use, but also it could be used as therapeutic use. So this is a short video. First, I designed where to inject my filler. So I draw some contour lines to give more smoother and dome-shaped elevation of the shoulder. And this is 7 to 8 centimeters length cannula, but you can just use 5 centimeters length, no problem. 19G is my favorite, but you can also use 18 or 21. But since you are using very high G prime HA filler, if you use 21, 22, injection force might be too strong. And gentle molding should be followed to create very smooth transition between injected and non-injected areas. And by approaching from 2 or 3 entry points, you can finally create quite smooth contour of the shoulder. And after that, 10 to 15 cc is my general use of amount of HA filler, 10 to 15 per side. So compared to buttock or other body areas, breast, we only use less amount relatively. Gentle molding using ointment. It's not really painful. So right side done, left side not done yet. So we see the clear difference. And after that, I draw the trapezius muscle, and the upper part should be the targeted, and 2 centimeters apart spacing between 2 entry points, and quite easy. So the result is quite good. And using only 30 ml and some toxin, you can create quite more elegant upper body silhouette. A male patient could be also suitable, but more volume of filler will be required. This is my conclusion now. So using these 3 treatments in combination, we can achieve a very effective, well-defined, refined upper body silhouette, especially when the patient is in a sleeveless outfit. You can see more obvious changes and better improvement. But don't forget to undercorrect. Always correct 70%, and if you need more amount, then you can just proceed next injections. Okay, that's it, my lecture. Thank you for your attention. Before wrapping up, I would like to announce one big event coming up in this country, Bangkok. 2 months later, ASL is coming back. So everyone who is interested, you are all more than welcome. Thank you very much.
Thank you, Dr. Choi. That was a wonderful technique you showed. Yeah, please, you have to stay back. Dr. Lucas from Australia, my friend, talks. Okay, the girls are really happy. So he talks about contouring the buttocks and enhancing the buttocks with Kaha and CMC.
Yeah.
Lucas.
Thank you, Anil. Thank you, everyone, for staying and for listening to my talk tonight. I'm here today to talk about the contouring effects for hydroxylapatite, CMC, for buttocks. So this is me. This is a non-sponsored talk as well. I'm originally from Brazil, and obviously I have to talk about buttocks as a consequence, right? So pretty much I'm going to talk about CMC being used for buttock augmentation. So we all know that there's a lot of biostimulators around that promote skin quality and everything, but I found that in the market, and especially with my patients, most of the patients, they want the skin quality, but they want some volumetric contouring, right? So it's not just about getting the skin quality better, right? So I was using different types of biostimulators, in particular PLLA before, and the results were mostly skin and not so much contour. So I started using calcium hydroxylapatite CMC, which is a filler that has the microspheres and the gel particle, and that can actually promote some immediate and visible effects, right? No skin sensitivity test, like can be presented in many different ways. So calcium hydroxylapatite works in different ways, right? So it depends on how you use the product. So it can produce immediate volume. It will always produce some collagen stimulation, some adipogenesis, and give some long-lasting results. Now, one thing that sort of it took me a while to understand is that when you talk about calcium hydroxylapatite CMC, you actually have a multitude of different products within that same product, okay, like depending on how you use it. So if you use it undiluted, you have one product. If you use it diluted, which means one-to-one dilution, you have a different product. And if you use it hyperdiluted, you have different product. And each way, you're going to get completely different results. So the elasticity, the G prime, the capacity to promote tissue proliferation and lifting will depend on what dilution you're using, right? And one thing that I found was that there was this global consensus that was done by experts all around the world, and that was done in 2019. And one of the things was that they were hyperdiluting when they were using on butts, right? And it was very interesting because I was like, but I don't want hyperdiluted. I want volume, I want contour, I want shape. Okay, like, and I want something that it's noticeable. And that's what my patients were wanting as well. So the dilutions that they were using were mostly for skin quality, not for buttock enhancement, right? So I was like, okay, so I'm going to go against all the experts in the world and, you know, like change the protocols and see what happens, right? So patients that were coming to see me, they wanted the volume, but then I noticed the trend as well. So a lot of the patients that were coming, they were not suitable candidates for surgical procedures, right? So you have young, thin females or mothers after giving birth, and they actually do not have fat for me to harvest, for me to inject, to do, for example, a BBL, or they don't want an implant. Like, for example, in Australia, an implant is still a bit of a hard, you know, like not many people doing it. So how can we actually address that and give nice results? Doing no surgery, minimally invasive procedures. We can use hyaluronic acid, great, but then if you're using very high amounts of hyaluronic acid like they do in Brazil, they put like 200 mils on each buttock. Okay, like first, it's cost prohibitive. Second, there are risks, there's migration, there's the whole issue with BDDE and so on. So I started investigating about calcium hydroxylapatite CMC and its capacity to actually promote lifting of the tissue, right? And then investigating, you see that there's a bit of a crossover between that CMC gel and the actual collagen production at about 6 to 8 weeks, where you have collagen stimulation, but the CMC gel is already dropping volume a little bit. But by doing that and actually doing top up at about 6 to 8 weeks, you can significantly exacerbate the results, right? Because you pretty much double the effect, even though you're using the same amount. And when you talk about concentration, now there's a lot of studies showing that when you use a 1-to-1 dilution or close to 1-to-1 dilution, 1:0.5 or 1-to-1, you actually have maximum biostimulation, maximum collagen production, because it's all about creating that microenvironment that it's going to facilitate for tissue to actually grow and develop, right? So when you find that balance between immediate lifting and longer-term biostimulation, then you start getting some better results longer term. And using that, and obviously I didn't come up with that on my own, you know, like I used the studies to back me up. I saw that, you know, like maybe if we use that 1-to-1 dilution, I can use more products, I can actually deliver better results. But then you have to select your patients properly, right? So patients that had severe deficits were not really good candidates, right? So if you need a lot of volume, if you need a lot of tissue proliferation, you're probably not going to achieve that. But if you want some mild lifting, some mild contouring, and what I found was there were a lot of patients that were actually wanting, for example, hip dip corrections, right? And just sort of like that nice contour that gives a different shape to the bum without actually having a big bum. So those patients were the ideal patients, right? That they were not wanting surgical treatments, that they were a bit younger, you know, like I said, like younger females, thin females, or even males, nothing, you know, like I still treat males as well. And then I started assessing patients and saw that, for example, even patients that already had nice volume, they wanted better shape, right? So pretty much like developed a protocol, which was create quadrants, okay, like dividing the butt in 4 quadrants, and deciding where the patient wants and focusing most of your treatment on that area. So for example, that first patient is to create a lifting and contouring effect. That second patient was more of an overall improvement and volumization. And then you can play around with your entry points and everything. And then when you look at results, you know, like for a few months apart, so 3 months apart, those were 2 treatments, 1-to-1, 4 syringes on each side. Okay, like so you use 4 syringes here, 4 syringes there. And then you look at the final result and you have a much nicer shaped buttock. Okay, like so for example, if you compare here, you see that it's much rounder, much more defined, and it ends up looking a lot more lifted, right? So the idea here was to actually correct volume, to improve volume, to use a biostimulator, but not just to correct cellulite, not just to correct skin quality or anything like that. And playing with it, you could actually go even with patients that also obviously did have a lot of laxity, you know, like but still weren't wanting a big butt. A big butt was not an option, and we cannot do that big butt, you know, like but we can give much better shape, much better contour if we use the right approach. So for example, in this patient here, same thing, we used 5 syringes per side because she needed a lot more, and I actually focused more on the lower buttock against as well, that focus that we always have to go on the upper quadrants, you know, like to give that lift. So you can actually use, because it's a filler that it's very viscous and doesn't migrate, so you could actually use on parts that you want to specifically enhance. So for someone like this patient, she was devastated. She wouldn't use skirts. She wouldn't use bikinis, you know, like and then we ended up giving a much better contour for her butt. So, and this result actually became very easily reproducible, right? So you could see that, you know, like on a lot of different types of buttock shapes, sizes, you know, like that we could do those treatments and still have very nice results, right? So for example, for hip dips, you know, like just making it more of a rounder butt, you know, like and one thing that was quite interesting for me is that a lot of the patients would ask first about costs, you know, like isn't that cost prohibitive? But patients that were seeking body treatments, it was quite obvious that they actually wanted the results, right? So pricing it slightly different and giving them the results that they need, they would happily go. Now we have performed hundreds of cases. We haven't had any complications whatsoever, right? So again, showing that it was a much safer procedure than, for example, when we do the face, where we have more complications, more nodules and stuff like that. So with that, we'll just wrap it up, and thank you very much for listening.
Thank you, Lucas.
Thanks, Daniel.
May I know, can we dissolve Kaha?
No, so you can't dissolve Kaha. So what you can do, if you have nodules, you can flush it down with saline. But once injected, you can't dissolve it. Yeah.
Okay, thank you very
Thank you.
much. So we move on. And we have Dr. Sue Ong before you, ma'am. Dr. Sue is here. Yeah, sorry. She talks about botulinum toxin for body contouring. This is a split-side case series comparing conventional and nerve-guided injection techniques.
Hello. Good evening, everyone. I'll be talking about botulinum toxin for body contouring, a slick side case series comparing conventional and nerve-guided injection technique. So as we all know, botulinum toxin is one of the most common cosmetic procedure and it has a long history of use. However, nowadays, especially in Asian country, there is an increasing use of the botulinum toxin off-labelly for the body contouring. The targeted area like the shoulder, like Dr. Choi already mentioned, and arm contouring and lower leg, especially the calf, because the Asian woman, if they are not very athletic, the quadriceps are not that strong, and even if they have it, the hypertrophy is very mild. So what's the difference between the toxin for facial wrinkles and the toxin for the body contouring? The difference is the characteristic of the target muscles and the treatment response. So for the facial wrinkles, we target the small, highly active muscle. So it produces the fast functional relaxation, not changing the muscle volume. However, in the body contouring, it targets the large and strong muscle, which is not highly active, but give a sustained contraction, so leading to the prolonged inactivity, causing the diffuse atrophy and causing the structural volume reduction. That's why the result is slower. At the same time, the recurrence is also slower. So what about the protocol and the dosing? Currently, there is no standard regarding dosing and treatment protocol, and it's widely varied across the practitioner. So what is the practical challenge for the body for the toxin? Body contouring require much higher toxin doses than the facial wrinkles treatment, leading to the increased treatment cost and as well as increased risk of antibody formation. So there is the need for the search of the minimal effective dose to balance the efficacy, cost, and immunogenic risks. So there's been increasing report of the secondary non-responsive to the botulinum toxin, which means they're resistant to the botulinum toxin, especially in the therapeutic uses where you need to use a higher amount of the toxin doses for a quite long time. However, in aesthetic uses, the rates are low, but we still have to pay attention because these days people use the toxin at the young age using the off-label high-dose treatment like the body contouring and the high-dose intradermal toxin injection. So these long-term cumulative doses can be equivalent to the higher therapeutic dose. So we might be really concerned about the immunogenic problem as well. So how do we look for the minimal effective dose? What do we have to target? The intramuscular nerve arborization. So let's go back to the basis. We have to remember that toxin work at the motor end plane, not at the whole muscle. And if you look at these dose-dependent curve, for the toxin doses, once it reaches the certain points of the doses, more toxin doesn't increase the effect. That's why accuracy matter more than the total dose. So the key principle is target area rich in intramuscular neural arborization. So these have come across the numerous study published by Yi et al. It mentions the important insights regarding the intramuscular neural distribution relevant to the body contouring. So I have come across this paper, and this is my study. I have compared the split side, one side conventional injection, one side intramuscular nerve distribution-based injection. I evaluate the difference in mapping, dosings, and the clinical outcome. So let's start with the shoulder contouring. So for the bulky shoulder, it makes the neck appear shorter and the bulky shoulder make it less elegant. It also has a functional problem like the neck and shoulder pain, tension, headaches, limited range of motions. And the muscle involved is the superior trapezius. So let's start with the conventional injection, the mapping. My prominent triangular area, which is bordered by the neckline, shoulder line, and a horizontal line, stay 2 centimeters medial to the acromion to avoid the spinal accessory nerve diffusions and not them cross the neckline to prevent unnecessary neck muscle weakness. So inject 2 centimeters apart, like Dr. Choi already mentioned about that. The dosage depends like 30 to the 50, depending on the bulk of the muscle. So what about the publication that I'm references, Yi et al., according to the study by Yi et al., it mentioned that zones of the maximum neural arborization is here at the pupper box area. And he also mentioned that we should avoid this yellow box area to avoid the injury to the nerve trunk. So based on this anatomical study, when I map into the real patients, this is what we got. This pupper box, in real practice, it crossed the neckline. So when I do the injection, I stay lateral to the neckline, usually just 2 points, but I add a little bit extra 1 point with the smaller doses if needed on the area with the high, maximum muscle back as well. So this is how I do. And this is the difference in the mapping between conventionals and the intramuscular nerve distribution. And so this is the result before and after. Left side, I use a conventional treatment with higher doses like 40 unit botulinum toxin A. Right side, intramuscular nerve distribution base with a lesser dose like 25 unit toxin. As you can see, the neck appears longer and the shoulder is more relaxed and less bulky. And this is also another patient. This is 6 weeks. As you can see, the necks appear longer. And when you look from the front, we can see the result more. Her neck appear quite relaxed, and the shoulder more relaxed, and necks became longer. And this is also another case. I didn't have a chance to have her after photo. But if you look at her, I'm sure doctors from our country know who she is. The front side, this is after 8 weeks. The result is more pronounced. Both sides almost equally effective. Although I use the lesser doses on the right side with IM nerve distribution-based technique. So let's move on to the contouring. So when it comes to contouring, the muscle involved is the deltoid and the tricep brachii, and the increased circumference is often associated with subcutaneous fat rather than muscle alone. So combination treatment is needed for the optimal slimming and contouring. However, I'm sure many people these days like to have an arm more athletic and more toned these days. So frankly speaking, I don't have much experience and I don't have much cases to treat toxin for the contouring. So this is the deltoid, this is the tricep brachii. So how do we map conventionally? We inject 2 centimeters apart along the muscle back, 2 centimeters below the acromial line, and 2 centimeters above the humeral insertion line. And this is how we map. And what about the neuroarborization, according to the Yi et al., maximum neuroarborization is here. Anterior and posterior deltoid is here at the pupper box, and the middle deltoid is here. So when I do mapping, according to the anatomical study, this is how I map. So the injections, majority of the toxin doses I inject at the pupper box where we have the maximum nerve distribution, but I still inject a little bit, like I said before, on the area that has a maximum muscle back, but with the smaller doses. So this is the difference between the conventional and the nerve distribution-based injection. And the tricep brachii, the same, along the muscle back, 2 centimeters apart. And then for the neuroarborization, this is the, according to Yi et al., this is the place where we have the maximum neuroarborizations, and this is how I map on the real patient. However, when I compare the conventional and intramuscular nerve distribution, it is almost the same. I don't see much difference. So this is the result. As you can see, there's a slight decrease, although it is not very obvious on the contouring. You can see a slight decrease in the muscle bulk on the tricep brachii as well as the deltoid. And like I said earlier, I don't have much cases on people with the contouring with the toxin, so I'm still collecting the cases. And the last one is the cuff contouring. So the cuff contouring is muscle involved medial gastrocnemius, lateral gastrocnemius, soleus, and the fibularis longus. And for the conventional injection, this is how we do the mapping along the muscle back, 2 centimeters apart, like we said before. This is for the medial cuff, and this is for the lateral cuff. We do inject the lateral gastrocnemius as well as the fibularis longus. And we do inject like 50 to 100 units per site in total doses. And for the soleus, we don't normally ingest soleus for the first visit because which is really important for the maintaining the standing posture, and it's only consider injecting lower soleus if the distal bulk persists near the Achilles at the second session after 3 months. So, oopsie. This is the study by Yi et al. Zones of maximum neuroarborization for the medial gastrocnemius is here, and the lateral gastrocnemius is in the yellow box. So based on the anatomical study, when I do mapping on the real patients, this is what I got. And when I do injection, majority of the toxin goes at the red box, the area where maximum nerve distribution is there, and I still ingest some 1 point to 2 point in the area with the maximum muscle bulk is present. And so the same for the lateral. So this is the difference in the mapping between conventional and nerve distribution-based injection. So this is the result. For the cuff, we can clearly see the left side, I use a conventional method. The right side, I use a IM nerve distribution base, like a dosage around like 30% less than the conventional injection technique. As you can see, the results are comparable for the both sides, and even after 6 weeks. And this is 4 months after, it still maintained the result, both sides equally, almost. And this is another case. For this case, I did not inject the lateral gastrocnemius because she doesn't have much bulk, so I only inject at the medial with a lesser dose on the right side. And as you can see, the result is still comparable with the conventional treatment with the larger doses. And this is the last case. As you can see, the comparison, left side conventional and right side is IM nerve distribution. It is still the result is still comparable. So this is the end. So according to my study, IM nerve distribution injection technique has a comparison result with the conventional treatment with the lower doses. However, I still have limited cases, so I'm still collecting the cases to make my findings stronger. Thank you.
Thank you, Dr. Su. Dr. Su, just one question. Have you come across some motor weakness in these important muscles of the calf?
Frankly speaking, the toxin doses I use are quite small, so I don't have that problem. Yes.
Okay, thank you. So we have finally Dr. Sonia Sattler, who talks about the upper arm aesthetics, how to achieve beautiful arms from non-surgical to surgical. Dr. Sonia, please.
Thank you so much. Wonderful. There are so many people here, and I like it very much what we saw just now, because I do it totally different. So upper arms aesthetics. We would love to all look like this. Maybe we have looked like this, but I'm a little older, and we go more into the aging process of the arms. So these are my disclosures, but this is completely independent to accompany this lecture. This is my clinic, 29 years now. I'm in my 30th year of aesthetics, and my clinic is really a big clinic with plastic surgery, different divisions, research center. So I know many things, but actually the clinic is built on fat. Because in my clinic we have performed 40,000 liposuctions in all body areas. So we are really a lot on the way with a body, and now I want to introduce you a little bit not surgical to surgical. How to assess it correctly and what to do when. Because we have different main aesthetic problems in the arms, and I would love to have only slim patients like my Asian colleagues to shape the arm with a toxin, but this is not reality in Germany. Reality is we have either too much volume or we have too much skin, especially now also the GLP-1 patients who lose a lot of weight. We get very bad skin quality in our aging process, especially in the anterior and medial part, and very thin skin. You know, it's not a UV exposed area. And we have mixed types. So when you look at the soft tissue of the upper arm, it's amazing that the fat tissue is kind of gathered in the posterior area. And only there we have 2 layers of fat. If you look around the body, like the abdomen or even the face, we have a superficial layer of fat, then we have a superficial fascia, and then we have a deep layer of fat. So in the arms, only the posterior area has these 2 levels of fat. And that makes them so heavy, because if we gain weight, we gain weight in the posterior part. This is how it looks like when it's bad. Lip edema can be also a possible disease in the background. But of course, this patient is not possible to be anyhow better, to get better with any non-invasive treatment. We have to be very honest. So if they come and say, okay, even let's do CoolSculpting, the cryolipolysis, I mean, that's 1 centimeter max. And so they're very unhappy if you offer that to them. So that's the wrong patient for minimal invasive. Then we have these patients. I call it macroelastosis. These are the GLP-1s, but these are also the aged, slim patients who suddenly have loss of fat, a loss of muscle, and then they really have these winking arms around. So this patient is also a challenge for minimal invasive, as it is very hard to really reduce this fat. And you see she had already an upper arm lift surgically before, so she's focused on her arms, and still, you know, this elastosis added up over time. This is the condition we see the most in Caucasians. We have this upper arm elastosis micro, which means bad skin quality, superficial wrinkling, and this is, of course, very nice to treat with minimal invasive approaches. But I want to really get you going with the right picture taking, and I think it's very difficult to take pictures of the arms. I show you now the same patient, 3 pictures taken in 30 seconds. That's picture number 1. You think, oh, that's type 2 or 3, a little bit skin quality problem. But now this is her just a little bit rotating inner rotation of the arms. And finally, this is when she lifts up her elbow. So she has not only a skin quality problem, she has also a connective tissue problem below. And so this is the same patient within 1 minute. So picture taking before and after, which are our best friends actually, is very difficult with arms. And only this 90 degrees is actually not enough in my belief. So my toolbox for our upper arm aesthetics. First, volume reduction. For those who have volume, it's really the liposuction, 2-mess and local anesthesia, with or without subcutaneous energy-based devices. We have things like BodyTite, we have things like Renuvion, different energy-based devices to give this dermal layer another structural support with energy-based device. Then, of course, we have biostimulation agents like CAHA, or also biostimulation through microfocused ultrasound with visualization, which is on label nowadays. And then, of course, we have also the combination of both. You can also add non-invasive RF, because all biostimulators will act better over time if you add energy-based devices, non-invasive, to them. And of course, if you have too much skin, you really have to send this patient to your surgical colleague, and then it needs to have, they need to perform a skin reduction surgically. So an upper arm lift, which leaves this long scar which you saw. So the right assessment leads you to the right diagnosis. And I show you pictures. This is before and after a liposuction. This patient is happy already with that. That's what you can achieve. Let's go a little bit into fibroblast, because we had it in the other room also, and I like to show you a little bit the stimulating part. We are now thinking more regenerative. And we know that all this extracellular matrix has a mechanobiology, and our fibroblasts actually only function if they have enough attachment to fibers, collagen fibers and elastic fibers. So if they are going to sleep, like here in the aging process, you see them very round. They have not enough attachment, so they will not build up extracellular matrix. So we really want to keep them alive, let's call it this way, not keep going them and getting them to sleep, with bioregeneration. So, you know, if you listen to me on Sunday, I truly love biostimulator, but I know there's far too much injected at this point. You know, it's not a volumizing HA replacement. Biostimulation takes time, over time. And biostimulation can be only regenerative if you have no or less as possible inflammation. So we look at this, at the size as well as at the shape of our biostimulating injectables. So the small microspheres will be swallowed by the macrophages within weeks. They will not act long. They need to have a special size, or at least a reasonable size, to stay there in your tissue for a longer period. And flaky shapes have more rough attachments to your extracellular matrix, which of course function well, but they're sometimes not so easy to control when it goes through the inflammatory pathway. Here you see different product, different shapes, they all function, but in different pathways, okay? So I'm at the moment at the point of CAHA more than PLLA, although there's a product coming out from or is out in Europe, PLLA in a microsphere round shape, which is now interesting because it's less inflammatory. So let's see I spoke in the complication, or we talked about that in the complication session. Really know your product and don't hop in one session, one patient with this and the other patient with this. So here there's enough about inflammation, non-inflammation out there now. There are enough publications, you can look through them. So we want the regenerative mechanism to have really a nice outcome over time. And this is a super old slide, but really be aware biostimulation is acting long-term. So your injected material will act for more than a year. And then it will add collagen, collagen, and collagen. So every biostimulator can do a fibrosis if it's done too much. And then, of course, you need to understand for the arm area, it's very thin, the layer which we want to inject. So if you want to add volume, with the CAHA particles, you can play around with the dilution. If you want to add volume, you use a 1-to-1 dilution because it gives you kind of a support also by volume. A higher dilution will give you no support. And where do you inject that? You inject it subcutaneously, of course. Adding on microfocused ultrasound is valuable. There's, microfocused ultrasound with visualization. You can see where the superficial fascia is in the posterior area, and you can also see where your dermal layer, or maybe even a fascial layer, is in the medial area. Know your energy-based devices. I'm so long in the market. I can tell you, every company tells you different things, and they do all wonderful things, but know which depth you're reaching and know what you want to achieve and what is your patient population for it. So in body areas, it's now on label really also with a microfocused ultrasound, which is brand new for arms and abdomen. But of course, we can also use non-invasive RF if you have a biostimulator inside already. This is the on-label treatment for body areas with microfocused ultrasound. It's worth it, and especially if you have a thicker dermis in the posterior level, it's with nice results. The combination has been shown by Gabriela Casabona and years ago. And there's a nice publication out of Asia here from Singapore, Silvia Ramirez, showing the combination also. And these are predictable results. And these are the main patients who love to have a good skin quality and nicer arms and dare to wear a tank top again. And you can see this is the patient I showed you in the beginning. This is my result. It's predictable. So combination of microfocused ultrasound with biostimulation with CAHA. In my hands, a valuable combination. And this is the slide about amounts. Because, 10 to 10 square centimeters you can put everywhere on your body, on your arm, on your leg, on your abdomen. And I think this is what you need for a good result. Once a year, not more. Because this is what I did, my mistake. This patient came back after 3 months, it's years ago, and she said, oh, it's nothing functioning, I don't see any result. So I added more CAHA. And then she came 1 more year not to my office, and she went to non-invasive RF and this and that, and then she came and said, oh, give me some neurotoxin. And I said, what about your arms? And she said, yeah, listen, you did something to me, because my arms, well, they might look nice, but I can't enter my jackets anymore. Okay, so they volumized over time. So this is what biostimulators do over time. And if you activate them with energy-based devices, some of the patients will perform and grow volume over time. So finally, too much skin. This is a surgical approach. You all agree this we can't do with minimal invasive, but you have this long scar. And to be honest, if this arm looks nicer, too much, yes, it does, but not super nice. So my take-home message for you is listen to your patient's wishes and expectations and guide these expectations. It's very hard in arms. And offer your patient the right treatment option after your assessment or diagnose. I think we really are doctors, and when we can't perform something properly, like a surgical approach, I cannot perform, I will send it to my plastic surgeon. Or vice versa. The plastic surgeon does the surgical approach, but then the skin quality is still bad. So we need to work together. I truly believe in that. So this is an announcement for Hong Kong. If you want to join this group, ISDS, we've been twice to Bangkok, many times. It's worth looking at. It's a good group to learn. Thank you so much.
Thank you, Dr. Sonia. Do we have any questions for the speakers? No? You want to? Yeah, please. Come up to the mic so we can also hear. You want to talk to Dr. Sonia directly? You can speak in the mic.
All right, so for Dr. Sonia, so you did mention like activating biostimulators with energy-based devices. And from your experience, you had a patient activated with non-invasive RF, twice CAHA, with MFU. But then, what is the idea about growing the biostimulated area when it comes to the arms, compared to putting the CAHA with the ultherapy and not growing the biostimulator? I didn't quite
So
get
the
that.
patient did it by herself, adding non-invasive RF. It was not my idea at that time. But I did the microfocus ultrasound and the CAHA in one session. First the microfocus ultrasound and then the CAHA subcutaneously injected. And then I sent her away. But then she came back and got another CAHA. And then she started searching around because she was not patient. She was looking for more and added non-invasive RF all the time, let's say all the time, two cycles. And this is what our patients do. They do, and if they are not patient, they need a lot of education to calm down with biostimulation because it takes time. So, but now I know also my patients who cannot afford maybe microfocus ultrasound, I send them now to the spa for 8 sessions, non-invasive RF, but they do the radius with me. Okay, so that's also possible.
Dr. Sonia, how do you compare the biostimulation between CAHA and PLLA?
Okay, so I have a long history with PLLA, this classical sculpture, so that's why it's not in my clinic. Okay, because it's nothing new. I had it 20 years ago already, and we saw no problems with HIV patients. At that time, it was for this issue. But at the minute we injected into immune-competent patients, we saw different outcomes, not controllable. It's working for sure. The problem is one patient gets a high fibrosis or late onset granuloma, and others look fantastic. And I don't know which one. I think it has a lot to do with your immune system. So I'm more safe in my clinic with not the flaky part. I think it's not about the product PLLA, so that's why I'm interested also in the microspheres with PLLA. It's about the flake structure, which makes it more aggressive. You know, and I think the less aggression we have, the better. And I want to control what I do. And it's easier to control at this point for me with CAHA.
But you feel PLLA effect lasts longer because it sets in late and...
No, I don't think there's any comparable study. It's a matter of amounts, how much you put into this size of tissue, how big the area is. And you see, if you produce collagen fibers, they last for years. It's very easy if you do like what is said, 3 vials on one side. I get stressed because not every patient needs 3 vials. I think for some it's too much, for those who react more. And so for biostimulating agents, I do 1 session only and wait and see 3 months at least, even with PLLA, I would do that with sculpture, and see how the reaction is, if there is any reaction, and maybe to take a second one, and then wait another 6 to 9 months. So sticking to a protocol for every patient has never functioned in my life. I think you have to be very honest and very individual with every patient.
Thank you. So any more questions? Come to the mic. You want to ask something? Come to the mic.
So a question for the speaker from Turkey.
Speaker who?
Yeah. That's it.
Okay.
Yeah, so you were talking about combining PDLA with HA, right? PDLA with HA for gluteal augmentation. And it was in milligrams, like 450 milligrams of PDLA and 150 milligrams of HA. And I didn't quite get the brand, or how did you mix them together?
It's a vial, consists of, as you said, 450 milligram PDLA and 150 milligram hyaluronic acid. It's a powder. We add nearly 60 milliliter sterile water and then 2 milliliter topical anesthesia with adrenaline, and then we put it on the vortex 20 minutes vortex mixing machine. And then it's ready to use. It's non-cross-link hyaluronic acid, but if we combine with high G prime hyaluronic acid, I use another filler
Filler.
from same brand,
Oh,
Dermacor.
okay. Dermacon.
Yeah.
I see.
It's
Yes,
from
because-
Korea.
Yeah, from Korea.
Yeah.
I see. All right. Yeah.
Okay, any more questions? Then maybe we can have a picture together, all the speakers.